Good afternoon, everyone. I'm Maureen Dobbins, the Director of Health Evidence, and welcome to our webinar today on chronic disease program planning. As you've been hearing from Diva, we have 4 reviews that we're going to talk about today. So I do recognize that there's a fair amount of information that we will be covering over the next 90 minutes or so, and also that some of the evidence might be more relevant for some of you, so we certainly would anticipate that if you need to leave early once we cover a particular topic that you might be coming and going. So this is the 4th topic of webinars that we have been holding in this past year. We've been very excited and also very happy to see the response to the calls for these webinars, and certainly it has suggested to us that you're liking the webinars and that we should be continuing those on in the future, and just recently received some additional funding to allow us to be providing more webinars throughout 2012, so hopefully you will be able to join us again. So we've just been asking you where you're from, those of you that are joining us today. Happy to see that we seem to be covering coast to coast anyway, from Newfoundland to British Columbia, with a fair number of you from Ontario, so very welcome to all of you. For those of you that are in southern Ontario, as I hear we're anticipating a snowstorm, maybe tomorrow will be a snow day for those of you in that area. Always exciting since we haven't seen too much of the white stuff this year. So for those of you that haven't joined us on previous webinars and maybe aren't that familiar with health evidence, this is the health evidence team, and I really do need to stress that this is a whole team effort in terms of putting a webinar together, from the identification of well-done reviews to the writing of the summary statements to the development of the PowerPoint presentation and organizing of today, as well as several of the team members in the room with me today to be able to answer questions that you might have about the evidence. Cara DeCorby and Robin Trainer looking for evidence right in the review if it's not right at the top of my head. And also a special thank you to Diva Trillis, who has been managing this whole project and has been really doing an outstanding job in organizing all of that. So just putting a face to our names, and certainly we love hearing feedback. And we certainly work towards tweaking all of our products and knowledge translation strategies as we hear from you. So certainly use the feedback loop, the comment, contact us loop on health evidence with your ideas about other activities we could be doing or suggestions around the webinars. So just very quickly, what is health evidence? And health evidence is a repository of reviews that evaluate the effectiveness of public health interventions. It's freely available online for anyone to use within Canada as well as internationally, and it's really to promote easier access to the best available evidence, so as to make it easier to use that evidence in practice. So we've just been asking you who had heard of health evidence, and for those of you that have answered, it's great to see that many of you are familiar with this resource. And why is it important to use, why did we create health evidence? And we certainly did a fair amount of consultation across the country. It's a way to save time since you don't have to search the large databases on your own. Everything in health evidence is relevant to public health practice, and you will only find reviews evaluating the effectiveness of public health practice as we define it here in Canada. We have a very transparent process for how we identify reviews, how we determine if they're relevant, how we assess them for quality, and then how we assign specific keywords to make it easier for you to search the registry. We also recognize that just having access to the best available evidence isn't the only thing that needs to happen to bring evidence to practice. So we also have created a number of additional resources and tools and support activities that you can also access. And we hope that it's easy for you to use. So this webinar today is brought to you through a CIHR funded grant that fell under the Meetings Planning and Dissemination Project, and we're very thankful for that funding that we received from CIHR. And particularly interesting with this grant was we proposed to find reviews that had been funded by CIHR that were relevant to public health practice, and then to disseminate the findings of those reviews through the public health audience with the use of these webinars. So that was actually really an interesting project for us to do, to identify Canadian reviews that were funded by a Canadian organization that are relevant to public health. So today we're talking about 4 reviews. The first one we'll discuss is by Booth, conducted in 2004, Addressing Childhood Obesity, the Evidence for Action, which is really a review of reviews. So this is it's a very complex, comprehensive document that is pulling together multiple reviews and different kinds of reviews, and we'll delve more deeply into those findings shortly. The second review by Shiel in 2008, a systematic review of population health approaches to prevent type 2 diabetes, and this was a report commissioned by the Public Health Agency of Canada. The third review is by O'Brien, Aerobic Exercise Interventions for Adults Living with HIV/AIDS, and then the final one by Farmer in 2008, Printed Educational Materials, Effects on Professional Practice and Healthcare Outcomes, which is published in the Cochrane Library. And for those of you that have joined us on previous webinars, you also understand that this is a CIHR funded study, so we are doing an evaluation of the webinars as a knowledge translation strategy, and I would ask you, you will receive following the webinar an email from Jennifer McGugan at McMaster asking you to complete what I do promise is a 5-minute survey, very, very brief, just asking you a few questions to help us evaluate the usefulness of this KT strategy. And I mention that now just because I would anticipate some of you will leave the webinar early if not all of the 4 reviews are why you're here with us today. So just reminding you to do that. And also, if you do leave early, just to let you know that we will have a live discussion forum on Monday where we will post information from today's webinar as well as the results of all of the polling questions, and someone will be there to engage in discussion, answer questions, listen to your comments, and so hopefully you will have a chance to join us on Monday. So I'm just going to ask at this point if anyone on the line has any questions or comments. I will anticipate, unless I hear or see from you, that everyone can hear okay. And everything looks good, so we're going to jump right into it now. So our first summary statement is by Booth, published in 2004. And you might ask, actually, why are we presenting evidence on a review that's actually a number of years old? Still think this is very important in terms of this being a very comprehensive assessment of all of the reviews that had been conducted on this topic right up to 2004, and therefore thought it was important to highlight the results of this. So the first thing that we can point out here with our summary statements, this is the very top of the summary statement, is PICO, and we're just looking at we've asked you if you've heard of PICO before, and so we're seeing here as the results come in, which I can see but you can't, is the majority of you have heard of PICO. A few have said no. So just as a very quick recap, PICO is a wonderful way to help us think about what our research question is or what our practice issue is, and really helps us to clarify who the population is that we're interested in knowing something about, what are the interventions that we are interested in learning about, what are we comparing those interventions to, and what outcomes are we particularly interested in for that population and intervention. PICO can be very helpful in two ways. A little bit off topic here, but if you had an issue that arose in your local context for your health department and you sat down with a group to think about what that issue is, and now you're ready to go to search maybe health evidence or other information sources, it's very, very helpful to actually put into a sentence that question in its entirety, and to begin with being as specific as you can with those PICO components. And my interaction with public health decision makers over the years is that the more time that goes into refining that question, the more likely it is that you are going to be able to find some research evidence that addresses it. And many times it usually really helps clarify some ambiguity about what the question really is. So for example, what a particular population is, it might help you define that more clearly, or you might only be interested in certain outcomes. PICO can also be really helpful when you know what your PICO is. Then when you find a review, you should be able, by looking at the abstract, to be able to determine if that review actually is addressing your PICO question. So by clearly articulating ahead of time, who you're interested in, what the interventions are, what the outcomes are, it will likely only take a few seconds of reading for you to be able to decide if that review is on topic. So I'm just seeing here, I think there's a question of whether or not you can hear me. So can everyone hear me okay? Do I need to be a bit louder for some people? And I will just keep on talking as I'm waiting to just get an answer. Just have a few people mentioning that you're not hearing me well. Okay, so I'm going to keep going. If there are issues with the volume, please let us know. We'll do our best to address that on this end. So for Booth, what we know in terms of our PICO is that this review of reviews looked at the population were children and youth 0 to 18 years of age. They looked specifically at prevention and or treatment interventions for obesity. That was compared to usual care, so whatever would be naturally going on. And the outcome was adiposity, which is BMI or percent overweight, or a measure of dietary intake and or physical activity. So, and what you're seeing here is we've broken down our summary statement, which is we try to keep these as much as possible to 2 to 3 pages in length maximum to give you a very high-level snapshot of what the overall findings were of the review. A review of reviews like Booth is incredibly challenging to put into 2 to 3 pages. I can't recall how long the document was, but certainly sometimes the reviews, some of you that have printed off an entire Cochrane review will know that all the tables in that sometimes might come out to being over 100 pages. So we try to keep it as short and succinct as possible. So I'm just told this particular review is about 70 pages long. So let's talk about what the overall conclusions are from this review of reviews. Basically, the interventions showed improvement in obesity outcomes. Interventions that showed improvement in obesity outcomes promoted the consumption of a healthier diet plus exercise. And this is in comparison to diet alone. So those two components together were important. Increased physical activity in and out of school showed improvements. Healthier diet among school-aged children, as well as behavior modification strategies implemented alongside other strategies to improve diet and physical activity. So those were our basic overall findings on the positive end. The evidence was not conclusive enough to support dietary interventions on their own, alone as an intervention, dietary change interventions for preschool-aged children or minority populations, reinforcement after obesity treatment, or modifying factors such as age or duration at the time that the intervention was implemented. So the implications that result from this evidence is that public health should support programs that focus on diet and exercise together, physical activity behavior change, and dietary change interventions for school-aged children, and behavior modification with both diet and physical activity strategies together. And then due to a current lack of evidence, public health programs should not include a focus on specific elements of dietary interventions. Dietary interventions for preschool-aged children or minorities, reinforcement after obesity treatment, and a focus on modifying factors including age, setting, duration, or initial weight as a way to modify obesity outcomes. Other additional conclusions is that there was no impact on obesity outcomes for interventions on dietary change, cardiovascular risk factor reduction, primary prevention programs for obesity, lifestyle exercise strategies, and parental involvement. And there was no review level evidence was identified to address treatment of obesity in minority groups, which is also an important finding and definitely a call to action in terms of the need for future research, current and future research, to really be looking at and analyzing the data for different subpopulations. So based on those final conclusions, general implications would suggest that due to a lack of effectiveness, public health should also avoid a focus on cardiovascular risk factor interventions to modify obesity outcomes, primary prevention programs for obesity, and lifestyle exercise programs. And that there's no current evidence to inform how public health should address obesity treatment in minority groups, and programs for these groups should be evaluated and those evaluations shared. And so you will hear that a number of times today in this webinar, that we are suggesting that if health departments are implementing programs, that there is a very important need to do program evaluation to see what impact occurs as a result of certain interventions, and that's to help build our knowledge base with certain populations. So let's look at the evidence a little bit more closely, because that was really the very high level, pulling together many studies inherent in these reviews. And so our first outcome we're looking at is prevention of obesity, which in this review of reviews included 6 systematic reviews, including 34 studies, plus 6 narrative reviews of studies that were primarily of low to moderate methodological quality. And generally what we found there in terms of what the evidence indicated is that the interventions had no impact on obesity or cardiovascular prevention interventions. So if we look at the systematic review evidence, 4 reviews for which citation analysis was possible does not support obesity prevention programs. Many of these were school-based for the reduction of adiposity. And 7 of 26 studies identified a reduction. In additional systematic reviews, 1 review that included 16 studies, cardiovascular prevention programs were not effective in decreasing adiposity. And that was 7 of 77 studies showed a positive impact. And then in a narrative review, sorry, I thought I was just missing something on the bottom there. A narrative review, 6 reviews, there was insufficient evidence for obesity prevention as an adiposity reduction measure. So our implications for practice and policy as a result of all of these reviews is that public health decision makers should not rely on either obesity prevention or cardiovascular prevention programs for decreasing adiposity, given the current evidence from both systematic and narrative reviews. One of the things to point out here as well is that a review of a review is a very certain type of evidence, in that the more we synthesize evidence, the more information we lose about, and the less we can say about particular populations or particular interventions. So the greater the degree of synthesis, as in this case, then the more general the comments we can make. And generally, by and large, the results of this review illustrated that up until 2004, a number of the interventions that had been evaluated at that point were not resulting in the positive gains around obesity prevention as we would have hoped. So what is also important to keep in mind is that we now have several more years of evidence of studies that have been conducted. We continue to utilize different frameworks, different theories to help inform our interventions. And so it would also be important to see what else has been evaluated, what other reviews are available, and synthesize that has been published more recently with these findings as well. When we look at diet versus diet and exercise, the evidence comes from 5 reviews. And the evidence tells us that exercise programs combined with a dietary intervention offered some improvement in adiposity, and this was found in 6 of 10 studies. However, the extent to which benefits are sustained in the long term is unclear. And this has definitely been a long-term issue that we've seen in the literature for many years, in terms of we might be able to get some gains in the short term, immediately post-intervention, but that we also need to follow children following that intervention in the longer term to really determine whether or not these interventions have that long-term impact. So based on this evidence, the implications for practice are that public health decision makers should promote diet and exercise together as opposed to diet alone for the secondary prevention of obesity, and evaluate whether long-term benefits are realized. When we look at dietary interventions, we have 1 meta-analysis from 17 studies and 1 review of a single study. And just briefly before I talk about those results, a meta-analysis, just for those of you that might not have heard that term, recently a meta-analysis statistically combines the results of all of those 17 studies into one overall numerical number. So it's a way to, for lack of a better term, and to oversimplify it, it's really a way of averaging the results of those 17 studies to give us an actual effect size, a number. So we have 1 meta-analysis and then 1 review that included only 1 study. And the evidence here tells us is that there was no impact of specific elements of dietary interventions on weight loss. So our implications for practice and policy here is based on these 2 systematic reviews of fair quality. There is insufficient evidence to recommend any specific elements of dietary interventions for obesity reduction. So let's look at physical activity and behavior change, which the evidence here comes from 8 reviews. And the evidence tells us that physical activity during school hours, when that's our intervention, high-quality review evidence shows that school-based interventions are effective in increasing physical activity during school hours. So that's definitely a really good thing to see, and that we do have that ability to alter environments wherein children spend a fair amount of their time to get them to spend more time engaging in physical activity while they're at school. When we look at physical activity outside of school hours, there is some, we're seeing mixed evidence that school-based interventions increase physical activity outside of the school hours, and what is meant by mixed is here we see that some studies reporting a positive increase in physical activity outside of school hours and other studies not seeing that change, and that overall it's a bit unclear what really is the truth there about increasing physical activity outside of school. Implications for practice and policy, therefore, are that public health should promote physical activity behavior change interventions to increase physical activity during school hours. Programs should be evaluated to determine whether physical activity outside school hours is increased. And evaluations conducted by public health should ideally include long-term follow-up into adulthood. So likely very easy for us to say that sitting here in a room that we need to be doing these long-term follow-ups, so recognizing that that is a tall order, and that's something we likely all need to be advocating for in terms of resources to allow us to determine whether or not we can achieve some longer-term outcomes, with the philosophy being that if we can build this into children's lives from the beginning, that this is something they will maintain later in life. So strategies, moving on now to strategies to promote dietary change. The evidence comes from 7 systematic reviews and 5 narrative reviews, and analysis according to behavior change model. So our evidence here tells us among preschool children, 7 of 10 studies in 2 systematic reviews offered mixed evidence that does not conclusively support specific behavioral or knowledge-based strategies to change food-related behavior. So for example, touch, smell, taste, new foods, modeling, repeated exposures. Among the school-based, 42 of 49 studies and 6 reviews showed some improvement in dietary behavior that was more closely attributed to behaviorally based approaches rather than knowledge-based approaches. Descriptions of strategies are not provided. And so one of the things that would be necessary for you to be aware of is if you were to access the booth review, in most instances, you will likely needing to be then identifying the individual reviews and looking at those a little bit more closely to get a better description of these strategies. And that's going back to what I was saying earlier, that the more we synthesize evidence, then the more we lose in terms of being able to talk about specifics. With respect to minority populations, there was one review of low methodological quality that offered no definitive conclusion that dietary interventions were effective. So what are our implications for policy and practice based on this evidence? Public health should not rely on either behavioral or knowledge-based approaches to improve preschool children's dietary behavior. That public health should use and evaluate behaviorally based approaches to improve dietary behavior in school-based programs, and that public health should evaluate efforts to improve dietary behavior in minority populations in order to contribute to the evidence base. The booth review also looked at strategies around lifestyle exercise strategies, and this evidence came from 3 reviews, citing the same 3 studies, plus 1 meta-analysis. Lifestyle exercise was distinct from other exercise programs in that it first included activities of daily living, included caloric expenditure in small increments throughout the day, and there was no prescribed intensity. And the findings were that there was no impact on childhood obesity compared to either no exercise or other exercise based on the meta-analysis incorporating the widest range of evidence. So the implications for practice is that public health decision makers should not rely on lifestyle exercise to decrease childhood obesity. However, public health should consider other possible benefits to be derived from the promotion of lifestyle exercise. And then finally, we're going to look at parental involvement, which came from 4 reviews, including 13 studies and 1 meta-analysis. And parental involvement interventions varied with only one study directed solely at parents. So many times there might have been a school-based intervention, and part of that intervention included involving the parents in let's say, discussing behaviors, lifestyles with the children, or it might have had activities for parents to do with the children. So there was quite a range of interventions that were aimed at both children and parents, and the intensity of that varied throughout these studies. Intervention elements are not well described in the review. Again, it's at a very high level, so you would need to go to those individual reviews to learn more, but tend to be family-oriented and include homework assignments and parents motivating their children. And the evidence indicated there was no impact on childhood obesity treatment, even though there was good evidence in this topic area. So the message there is that it's not there's a lack of evidence, and it's not that the evidence isn't of a good quality. It's that this evidence illustrated no impact on childhood obesity. And the implications for practice and policy is that public health should not focus on parental involvement strategies as a way to improve childhood obesity treatment. Behavior modification strategies. There were 2 reviews of 9 studies and a meta-analysis. From this review, little information was provided regarding the nature of behavior modification strategies used. That the improvement in obesity status when behavior modification strategies were used with dietary and physical activity strategies in the short term. So there was some improvement noted there. That behavior modification, dietary, and physical activity strategies together demonstrated greater treatment effect than behavior modification in either dietary or physical activity. And there was no impact on additional or add-on self-control training on obesity status. So our implications here are behavior modification strategies should be considered for use with dietary and physical activity interventions, and ideally with all 3 strategies combined in aiming to improve obesity status. Public health should not focus on self-control training as an additional strategy for reducing obesity in children. And then we also have as an outcome reinforcement, which the evidence came from 1 review. And here we have a single small study of 15 subjects of fair quality in 1 review showed that periodic reinforcement after obesity treatment enhanced weight loss. However, our implication at this point is that there is very limited evidence at this time to support the provision of reinforcement following obesity treatment programs. It's hopeful that in the year since Booth was published that additional studies have come out and there would be further evidence to support this, and that certainly would be required on the part of a public health decision maker at this point to see what else has been published to add to hear this finding of 1 study. And then finally, the review looked at factors influencing obesity prevention. And again, the finding was that there's very limited evidence. There was, at that point, evidence examining the effect of setting, duration of treatment, and initial weight status upon which to assess the impact of these factors on obesity outcomes. It is possible that relationships between these factors and obesity may exist, however, they are unclear at this time. So the implications are that based on evidence available at the time, public health should not focus on modifying factors such as the setting, duration of treatment, age, and initial weight status to improve obesity outcomes. Where such factors are considered in obesity prevention efforts, they should be included in program evaluations to build on the currently available evidence. So again, I know many times that's not the answer you want to hear from researchers, is that more research is necessary. And I think what you will hear throughout the day is not necessarily full-blown randomized control trials. Certainly would be great. We definitely will always need those and other forms of evaluations, but those program evaluations that are done at the local health unit level to see if when you implement this in your setting, whether or not you're able to achieve the outcomes you were hoping for. So just back to what our overall conclusions are from this. I feel like we just threw an awful lot at you. So just as a recap, the interventions that showed improvement in obesity outcomes promoted the consumption of a healthier diet plus exercise over diet alone, increased physical activity in and out of school, healthier diet among school-aged children, and a combination of behavior modification strategies in addition to strategies to improve diet and increase physical activity. The evidence is not conclusive to support dietary interventions on their own. Dietary change interventions for preschool-age children or minority populations, reinforcement after obesity treatment, and modifying factors such as age, duration, and other important risk factors. I'm just going to get you to go to the next slide so we can read all of those, and then that there was no impact on obesity outcomes were observed for interventions on dietary change, cardiovascular risk factor reduction, primary prevention programs for obesity, lifestyle exercise strategies, and parental involvement. But also that at this point we still have that recognized lack of evidence, review level evidence to address treatment of obesity in minority groups. And overall, our implications being that public health should support programs that focus on diet and exercise, physical activity, behavior change, and dietary change interventions for school-aged children, and behavior modification with both diet and physical activity strategies. And that right now public health should not focus on programs that focus on specific elements of dietary interventions, the school age, the preschool age children, or minorities until we have more evidence on what works in these groups, reinforcement after obesity treatment, and looking at how to address specific risk factors. And then due to a lack of evidence, public health should also avoid a focus on the cardiovascular risk factor interventions to modify obesity outcomes, primary prevention programs, and lifestyle exercise programs. And that currently there's no evidence to inform how public health should address obesity treatment in minority groups, and programs for these groups need to be evaluated. So I feel like I've said that a number of times now. So there's a lot presented there, and also I'm not sure how familiar you were with that evidence, but I would anticipate that actually sounds somewhat negative for many of you, and leaving you wondering as to, well, what should we be doing? And rest assured, we will be coming back to more evidence that's been published more recently on some of these outcomes in the rest of the webinar. But at this point, I would just like to open it up to questions or comments, and I will do my best. We will do our best to address those. So, okay. So we have a question from Shoshana. Due to the raging prevalence of diabetes in Aboriginal populations, I'm curious as to why more studies haven't focused on minority populations. Thank you. I think that's a very important question to raise. And I'm not really sure I would have the answer to that question. Certainly, it could be challenges in accessing resources to conduct studies in certain populations. I know that certainly in the public health departments that I've interacted with a fair amount in the last couple of years, discussions and focus on inequities in health and the social determinants of health are becoming so much more upfront, and the major questions that people are asking in terms of thinking about who are our interventions impacting and who aren't they, and that we need to do more work to identify what works in different types of populations. And so I'm hopeful that since Booth has been published, that there is additional evidence out there, and certainly a call to action that very much more needs to be done on that in the coming years. Second question from Linda Taylor is, what's your guess at what we should be doing? That's a great question, Linda. Thank you. You know, I'd like to maybe put that on hold a little bit until we look at some of the other evidence as well, because I certainly agree that the results from Booth can be leaving us feeling, you know, well, what should we do? Almost raising our hands in the air in terms of, if all of this doesn't work, then what should we do? I guess the short answer to this might be as well that this is a problem that can't be fixed by just addressing one risk factor. That did jump out at me from this data, looking at this data, that it's more complicated than changing what we eat or how we eat or when we eat. It's really addressing entire ways of living. And so the idea that it's important for that one of the strategies that did show promise is exercise and nutrition together, I think is important. And thinking about it's a complex series of behaviors that all need to come together in order to really affect change. So I'm going to leave it at that for now. That's probably not addressing the whole answer, but perhaps in some of the other data we'll present, there'll be a few more discussion points. So just another comment from Shoshana, and I hope I'm saying your name correctly. I just wanted to note that I was really surprised that parental involvement was not shown to be beneficial for children with obesity, as they are the main providers of food in the home. Excellent comment as well. However, I can comment from a Cochrane review that I am in the process of updating right now, which is on school-based physical activity promotion interventions. And we have found similar findings there as well. In the original review that was published in 2009, and also in the update that we'll be hoping to publish shortly, is that the evidence tends to be very mixed here. And sometimes parental involvement as a component of the strategy seems to be important, and other times with that parental component included, the strategy hasn't resulted in a significant change in things like BMI, so body mass index, amount of time children are involved in physical activity. We looked more at physical activity, not exactly what children are eating. So I think that there is a trend there to see that, even though intuitively one would think that parents have to be involved in order to have success, and I would agree with that. It might be that we haven't figured out yet what are the best ways to involve parents in these bigger strategies. Another comment here from Penny says, regarding the lack of impact resulting from parental involvement, I am wondering whether you had looked at the type of interventions that had been conducted with those populations. Education, portion sizes, choice of foods purchased during grocery shopping versus behavior changing type of education. So one of the things, and that's a great point, Penny, one of the things that's really important here, and sorry to sound like a broken record, is when we get a review of reviews like Booth, it's synthesized at such a high level, you really end up losing what was done at that individual study level. So, as you know, I started out by saying this particular document by Booth, the printed version is 70 pages long, and so if the kind of detail that you need and that you're asking for was included in a review like this, it would probably be about 400 pages long and then likely have no chance of really being that useful to practice. So there wasn't anything that we can specifically comment on in terms of what was actually happening in the parental component beyond being able to say that the parents were involved around various types of activities. So it would be required to delve more deeply into that in the particular individual reviews and potentially even among those particular studies, because not all of the studies would have had that parental component. But you raise a very important issue there, and really great to see that critical thinking of these results in terms of those kinds of questions that we really would need to know, what exactly were the parents doing, what kind of education did the parents get around portion sizes, and all of those things that we now know are very, very important, and that additional knowledge and skill is needed. So there's an additional question here from Mark, and Mark asks, can you share documentation on what criteria you used in conducting the synthesis of systematic review and weighting process used for scoring? So I'm thinking here, okay, so if I have your question correct, Mark, you're asking us how we assessed Booth is what I think you're asking. And we would have used a very standard process for how you assess the quality of doing really a systematic review. So wanting to know if a clear PICO question was addressed. So were for example, in this case, Booth and the other authors, did they develop a specific PICO question? So were all the components of PICO clearly articulated? We assessed how they searched for the reviews to include in their review of reviews. Did they identify inclusion-exclusion criterion? Have they clearly articulated to us how they decided what was in or out? How did they assess the methodological quality of each of those systematic reviews? We would assess how they did the synthesis, so we would want them to have explained how did they extract data and how did they synthesize that evidence. And we, in terms of weighting, all of these criterion are given equal weight to give us an overall assessment of the quality of that review. So I'm hoping that answers your question, Mark. So this is really great to see in terms of lots and lots of discussion. It's really what we're hoping for in this type of a webinar. So from Barbara, we have the question, do you have any comments on the wider societal influence on childhood obesity? Example, proliferation of fast food restaurants advertised in the built environment. Is there any research on that kind of thing? Perhaps country studies with different public policy related to this kind of thing. Excellent question as well, Barbara. And I think keeping in mind, again, this review is a bit dated, and as would be the individual studies included in the review. And certainly there has been significantly more work done in the last number of years that do address these issues around the built environment, the requirement of fast food restaurants to identify the caloric amount of different food items. And while I can only give you snippets of some of the research that I've certainly seen over the years, I can't just off the top of my head quote a review that's been done on this, but we certainly know with respect to some studies that have been done where at the point of purchase, if consumers can actually see the fat content and caloric intake, caloric content of different food items, that they actually do make different food choices. As I try to say to my children when they ask me if pizza is healthy, I sometimes say that there might be other items that are more unhealthy but that we might not necessarily be eating a healthy thing, and that there are other items that would likely be healthier. So we know that we can impact consumer behavior by providing them with information right there in front of them as they are about to make their order. We also have other evidence that tells us that when we, for example, in vending machines put different food items, so healthier food items, and remove the non-healthy food items, that people will purchase those. And that when there are choices for healthier foods that are cheaper and or the only choice, that people will purchase those. What is lacking in some of that evidence, or certainly the last time I looked at some of that evidence, is whether or not there are significant and long-term impacts then on other health measures such as BMI and other risk factors for cardiovascular disease. But excellent points to make, and certainly important literature to be considering in terms of policy initiatives. So I'm going to take one more question before moving on to our other topics. Okay, sorry, I have three here, and then I'm going to move on. So a comment from Shoshana, one last comment. With the evidence that increase in in-school physical activity results in beneficial effect on childhood obesity, I believe that school boards and people formulating curriculum should be more responsible for implementing activity programs to prevent childhood obesity, other than just minimal physical education classes, requiring classes at too low a frequency to make a difference in childhood obesity. And you're definitely right, Shoshana, and that's certainly important findings from the physical activity review we're working on right now, that it's very, very important that children spend more time engaged in vigorous, moderate to vigorous physical activity to actually see changes in other indices of, let's say, fitness, measures of fitness. And that this goes beyond really policies that say X number of minutes must be spent engaged in activity to actual, I think, really a call for just exactly what is meant by that. So more likely support and guidance and resources to really help develop programs to help kids be more active during that time period. Another comment from Linda is, it's interesting that our approaches have been oddly void of mental health, wellness, and stress reduction along with effective parenting. We look at the food and exercise and rarely at the stressors involved in overeating, i.e. show me a fat kid and I'll show you a child medicating with food. You can substitute adult for child in that sense as well. And certainly I would invite, and I would assume there would be many, many comments that people would have to that, and I agree. And you're really addressing a key issue here around the challenges of doing research, and that when we start really trying to think about how an intervention impacts a certain health outcome, you know, we like to keep everything nice and controlled, and if it becomes too complicated, then it becomes much harder to really design that study. And so you're right, that likely you know, we have minimized really the importance of taking a holistic approach to this. And I think I was trying to get at that later in terms of what do we need to do, and that I think it needs to be something much more comprehensive that really gets at issues that we haven't addressed to date, and that is certainly, Linda, a call for action. And what I would like to say is I will ensure that this comment, your comment, Linda, is posted on our discussion forum, and invite those of you that are on the call with us today to post your comments there as well. And I would suspect that we could have a fairly hearty discussion about that. And finally, So Miriam, is there an established link between density of fast food outlets and neighborhood obesity rates amongst children? That's an excellent question that I don't have an answer for, but we can do some looking into that to see whether or not there's anything in health evidence that has addressed that to date. And if we do, we'll comment on that on the discussion forum on Monday. If we find something, we would definitely post that. But I think a very important question as well. So thank you. Thank you for that. That's really great, exciting to actually have that level of interaction. We haven't had that level of questions and comments, and I really appreciate your participation. So let's move on now. Our second review, published in 2008, the title is Population Health Approaches to Prevent Type 2 Diabetes, Evidence and Implications for Public Health. So our population here is the general population. Our intervention is population health interventions focused on preventing type 2 diabetes or its related risk factors through policy or changes in the social or physical environment. It's being compared to usual care, and our primary outcomes are prevention of type 2 diabetes or reducing the associated risk factors, for example, unhealthy weight, inadequate physical activity, and or poor nutrition. As you can see here, I forgot to point this out with the Booth review. What's highlighted in red there is this is a review that we consider to be very strong methodological quality, so it was given a rating of 9 out of a possible score of 10. If you were on the health evidence site and you wanted to see how we actually assessed this review, which criterion we didn't give it a yes to, you could click on the word here that is hyperlinked, and then that would take you to our assessment tool and you would see our rating. And that's available for every review on health evidence. So these findings, again, are interesting to say the least, and it's always a challenge to think about what do we say about the evidence? How do I depict what's there and provide it to you in what would be a very in the most useful package possible? So I've tried it this way. I'd be happy to hear your comments once you've heard the way they've been presented. But overall, our conclusions are that school-based interventions led to no effect on physical activity, nutrition, BMI, fruit and vegetable intake, energy from fat, total serum cholesterol, and VO2 max when we looked at the most rigorous studies. And I believe in this particular review that would be the results from 5 rigorous randomized controlled trials. So when we used the most rigorous evidence, we did not by and large see, or the authors did not see really effects on all of these risk factors. However, studies of less rigor, so studies that were less rigorous, did report improvements in triglycerides, physical activity, systolic and diastolic blood pressure, percentage body fat. They saw a smaller increase in BMI as children aged, and a decrease in waist circumference among boys, but not girls. So interesting here, and that was, I believe, the results from about 6 studies. Furthermore, community-based interventions led to an increase in self-reported physical activity. And then finally, among worksite-based interventions, this led to an increase in smoking cessation rates. So it was a bit of a struggle to think about what to say here, but overall, the general implications are that the most current rigorous evidence does not support school-based interventions to reduce type 2 diabetes or its risk factors. Findings from less rigorous studies do support the use of school-based intervention. And I guess I felt it was important there to provide, I guess, both ends of the continuum here. And if I can just maybe pause briefly for a minute to talk about why I've made a big deal out of this. What we know is there's a relationship between the rigor of research and the likelihood of finding a positive effect. of our intervention. So we know as studies are done in a more rigorous way, which then reduces bias, and all sorts of different kinds of bias. So the more rigorous we set up our study and the more rigorous we are in how we assemble our participants, how we collect data on them, how we measure the outcomes, the more rigorous we are, the less likely we are to see an effect of the intervention. Or if I say that the other way, the less rigorous our study is, the more likely we are to see a positive effect, but that positive effect is likely not as a result of the intervention. So it's a bit of a dilemma here in this particular review, because the authors of this review have assessed the evidence by the quality level. So they actually presented the evidence by the most rigorous studies, and then by studies of less rigor, and then ones that actually really were quite poor quality. And I have not included in this summary the results of the very poor quality studies. So in addition, at this point we would say community-based interventions are currently recommended for increasing physical activity, but again we need to be a bit careful here because this is based on limited evidence and also based on self-report. So we also can recognize that when participants are in studies, they may feel social desirability to respond in a certain way, and there certainly would be there would be pressures on participants participating in this study to be indicating that they might be behaving in a certain way more than maybe they are. So we need to be a bit careful here in this interpretation in terms of this self-reported physical activity increase. In terms of general implications, work-site-based interventions are suggested for increasing smoking cessation rates. Finally, there is limited good quality evidence. Results should be applied cautiously to public health practice, and any associated public health programs need to evaluate the impact of these interventions. So I thought it was important to mention this, that again, we see our role as trying to synthesize the evidence and provide it to the public health community in a format that's easy to use, easy to understand, but still see this as public health decision makers' role is to then take this evidence, decide what is important for them, and also to place it within the context of their local settings, and all the other ways of knowing and information that is used in decision making to decide what is the right course of action in your particular setting. So you may decide to use the evidence from the less rigorous study from this review. I would strongly encourage that if that were the case, that you would definitely want to be doing good program evaluation to see whether or not you were achieving those health impacts that you were hoping for. So I have a comment here from Carol that says, as of April 1st, our regional health authority will have smoke-free grounds. We will be providing smoking cessation aids to help staff quit if they wish. I'm glad to see that worksite-based interventions to reduce smoking cessations work, and I agree. And I mean to increase smoking cessation, so that's right. So there is some good evidence out there, and this is just one. There are actually many reviews available in health evidence and throughout the world, looking at various smoking cessation interventions, both within work sites and elsewhere, that could also add to this body of evidence. So you don't need to just rely on this one review for that, Carol. So those are our overall findings. If we just look a little bit more closely at what the particular findings are, as it results of the school-based interventions, as I said earlier, we have 5 randomized controlled trials of high methodological quality, and then 6 quasi-experimental studies of moderate quality. And just because not everyone might be familiar with that term quasi-experimental, what is meant here is that we still have an intervention group, we have a control group the difference here is that the allocation, so who ended up in the intervention and who ended up in the control, wasn't randomly allocated by the investigator. So it could have been that some groups just naturally were put into receiving the intervention and another group wasn't. So the most rigorous design takes that control away from the researcher, and you might use, for example, a computer to generate numbers that would then allocate people to different groups. That's the way you would achieve, if done correctly, less bias in your study. So among studies of moderate methodological quality, a statistically significant impact was observed, and these are the outcomes I mentioned earlier on triglycerides, our blood pressure, percentage body fat, participation in rigorous physical activity, waist circumference, and less of an increase in BMI compared to usual care. And I've also seen this again in the physical activity review we worked on, that BMI, particularly in children, still increases. We just see a smaller increase in comparison to a control group. What's also important here, it didn't come up in the Booth review, but is very, very important to all of this, is that in some instances we only observed positive effects among girls, and in other studies we only saw positive impacts among boys. And this has been identified for a number of years, not only that we need to be evaluating the data for males and females separately, but that our interventions likely need to be geared towards boys and girls differently. However, more research, again, is still needed to really understand that better. And then, as we said, amongst the most rigorous studies, we really did not see statistically significant positive impacts when we compared intervention to control groups on physical activity, diet, cholesterol, VO2 max, or BMI. So our evidence is mixed. Our rigorous studies generally report no effect. Lower quality studies are reporting statistically significant effects. School-based interventions may not be an effective public health strategy for reducing type 2 diabetes and its risk factors, or certainly in the way in which they were implemented here. Given some interventions affect boys and girls differently, we need to be thinking very carefully about the different facilitators and barriers to physical activity among boys and girls, and then planning our interventions accordingly. With the community-based interventions, which was based only on one study of moderate quality, and that's very important to keep in mind here. In this particular review, that's very limited evidence. But of one study of moderate methodological quality, a statistically significant impact was observed on self-reported physical activity. So community-based interventions are supported for increasing physical activity at this point, but you need to be careful with that based on the limited evidence, and maybe this could be an overestimation of the true effect based on that self-report measure. And again, you would want to be evaluating that impact if you were to implement it. And then for the worksite-based interventions, again, based on one study of moderate quality, and here we did see a statistically significant increase in smoking cessation rates. We see OR here refers to odds ratio of 1.38 with our 95% confidence interval between 1.05 and 1.81. And so what we can see here is that those who received the worksite-based intervention were 38 times more likely to quit smoking than those in the control group, and that the true effect, so if we ran this study 100 times, the true answer would lie between 5 times more likely and 81 times more likely to have quit smoking. So we have a fairly wide confidence interval there, but depending on the intensity of that worksite-based intervention, very promising results, even though at the lower end, the 1.05, the 5 times more likely, might still be compelling enough for you to implement that into practice. So very important here to be thinking about when we have confidence intervals. It's always very important to be looking for confidence intervals. You would want to be making your decision based on either end of the confidence interval rather than just on that odds ratio of 1.38. The full story here that this intervention is as equally likely to have an effect at the low end, the 1.05, as it is to achieve the 1.81. So when you make your decision, you have to be prepared for a result anywhere within that range. And if you think it's still important enough at a 5% increase in the smoking cessation rate, then you would want to be implementing. So our implication for practice here is that worksite-based interventions are recommended for increasing smoking cessation, and again, however that you might want to be doing some ongoing evaluation, also looking to other evidence that does exist as well. Certainly we know in health evidence alone, certainly a few years ago, there were over 70 good quality reviews looking at all sorts of different types of interventions on smoking related to smoking. So overall, our conclusions, again, just to reiterate, is that of our highest quality evidence, there are not positive effects on many of the risk factors. When we look at studies of lesser quality, we do see statistically significant findings on many of the risk factor outcomes. That there's very limited evidence, but there is evidence to suggest that community-based interventions are effective for physical activity as well as increasing smoking cessation rates. So I'm just going to open it up to questions or comments at this point. Okay, so I see that there's a few questions that have been asked, and this is why I have a whole group in here who are now frantically reading through reviews, looking for some additional information in those reviews to answer some of your questions. So one of them being, should we be focusing on women of childbearing age so we can tackle diabetes and pregnancy? Why is that they measured VO2 max for type 2 diabetes? Good question as well. So, I mean, why don't I address that one there? And I think what they were talking about here is in these studies, they were looking at other risk factors as well, and physical activity, lack of it being one of them, and also a good measure of fitness is VO2 max, and so why that was included. Now, one thing to keep in mind here is that the review included studies that had interventions that would evaluated reducing risk for type 2 diabetes or type 2 diabetes as well as other risk factors. And so an individual study might not necessarily have as its purpose to be addressing type 2 diabetes, but might have been addressing increasing physical activity. And one of the measures that they also looked at for that was VO2 max. So, it's a bit more complicated in terms of the studies that were allowed into this review. The review was asking a fairly broad question. And in the end, actually what we concluded is there really was not an outcome that looked specifically at type 2 diabetes rates. In the end, the evidence was all related to various factors around type 2 diabetes. And also what we could look at here is that this is just the result of one review, and certainly there are multiple reviews addressing all of these issues around obesity, physical activity, type 2 diabetes, and in this instance, multiple reviews would need to be looked at and synthesized in order to come up with an overall question. Coming back to the one on should we be focusing on women of childbearing age so we can tackle diabetes and pregnancy, and you're raising an excellent point here. I cannot say right now that I know if there's a review that specifically answers that question. I know that there is a team at McMaster University that is seeking funds to look at reducing the total amount of weight women gain during pregnancy, with the hypothesis that weight gain during pregnancy results in health outcomes for the fetus later in life. And so obviously my understanding from that team of researchers is there is a growing body of literature that shows this relationship between what happens during pregnancy and children and adults of that later on. And so you are likely right that there needs to be something going on there. I think there are some strategies underway. What we can also do for Monday is we can take a look to see if we have anything particularly answering that question, and if it is, we would provide a link to that on the discussion forum on that Monday. So just one more comment here, two more comments. So we have here, weakness of evidence described suggests interventions do not lend themselves to traditional randomized controlled trial approaches, and we should be looking at complex intervention methodologies, and you're very correct there. So again, this is not easy research to do, and when we try to just look at one component, so in a very tightly controlled trial, there's lots of other issues that come into play, and so the implementation of complex interventions, and as well as all of the complexities around how to best conduct research where there's multiple interventions and complex interventions needs to also occur. So we have an additional question. An issue here is, since statistical significance does not equate to clinical significance, the fact that there were no effects found in rigorous studies, but there were improvements shown in less rigorous studies, doesn't mean that there should be no school-based intervention. Also, rigorous studies may have used large samples, whereas the less rigorous studies may have used smaller sample sizes, making it more difficult to reach statistical significance. So yes, you're correct there in that I didn't tell you why those studies of less rigor were less rigorous. Sample size is definitely an issue. It could have been that they were underpowered to detect statistically significant findings. And sorry, I'm just reading very quickly here a note that's been passed to me about that. So the issue that we can think about here is we do need to, in those individual studies, demonstrate that, or ask whether or not they actually had enough power to report a statistically significant finding. But let's just go back, actually. The less rigorous studies were adequately powered because the less rigorous studies did all find a statistically significant effect. So what could be here is that the randomized control trials weren't large enough to find a statistically significant finding. I don't believe that that was addressed in the review, but we can keep looking for that. But the issue here being that there could be other reasons for, in the less rigorous studies, why they ended up finding a positive effect that has absolutely nothing to do with the intervention. There could have been differences in the groups at baseline. It could have something to do with how the measurements happened. So the groups might not have been equal. There's a number of factors that could have come into play that actually explain the positive results. And that's kind of the message there. And that when we better control for these differences, i.e. through a randomized control trial, then we no longer see that positive effect being maintained. So, and yes, I agree with you that there are instances in which it's very tricky to do randomized control trials, and therefore we need to look to additional forms of evidence to help inform us there. But at this point, we actually have a good number of studies here to help us look at this comparison. And the only other issue there is, I think, in terms of when we talk about statistical significance versus clinical significance, really to me those are two very different things. Statistical significance tells us whether we can be confident that the findings are true. Right? So when we have a statistically significant finding, that is telling us that we should feel confident that that answer is the truth. And so that's the first thing we want to know about a study is, did the intervention work, and can I believe that the intervention worked? That's statistical significance. The clinical significance comes into play that now if we know that it worked, did it work enough to warrant actually using that intervention in practice? So in other words, is the bang big enough for the buck? Did we find a big enough effect that implementing this intervention will be worth it? And that's what we mean by clinical significance. So hopefully that's helpful there. Okay, so I'm just going to move on now. We still have a little bit to go. So let's look at the O'Brien review that was published in 2010. And this is aerobic exercise interventions for adults living with HIV/AIDS, evidence and implications for public health. So we have adults that are 18 years of age and older living with HIV. The intervention was aerobic exercise performed at least 3 times a week for at least 4 weeks, including walking, jogging, cycling, rowing, stair stepping, and swimming versus usual care. And they looked at a number of interventions here related to immunologic and virologic indicators, cardiopulmonary measures, and psychological measures, strength, weight, and body composition. This was a very well done review. It scored a 10 out of 10. And overall, what we found here is that there was a significant impact on the CD4 count when they compared interval aerobic exercisers to non-exercisers, but there was no impact on the CD4 count, CD4 percentage, and viral load on all other types of exercisers. So when they just compared aerobic exercisers to non-exercisers, from constant exercise to no exercise, and from aerobic exercise plus progressive resistance training to no exercise, for any of those other comparisons, there was no impact on these other outcomes. With respect to cardiopulmonary outcomes, there was a positive improvement on all different kinds of measures on VO2 max, but no impact on the other cardiopulmonary measures such as maximum heart rate or time spent in exercise. And these were all the results of, up to this point, were meta-analyses done on multiple studies. For the strength outcome, they were unable to do a meta-analysis because the ways in which strength had been measured was quite different across the study. So we were just able, the reviewers were just able to look at the findings across individual studies, and 4 out of 5 studies found improvements in strength when they compared exercisers to the non-exercisers. For weight and body composition, there was a decrease in body fat, so a statistically significant decrease in body fat, and an increased change in leg muscle area. However, there was no change in body weight, BMI, waist or hip circumference, or waist-to-hip ratio, or fat mass. And then our final outcome was psychological improvement, and there was a statistically significant improvement in a depression dejection score in the exercisers versus non-exercisers. So again, it's really challenging to think about what are the implications for public health when the results are just so different across studies. So overall, the findings suggest that the promotion of aerobic exercise, while resulting in improvements for a small number of outcomes, does not positively impact most outcomes and may not be an effective public health strategy for this population. However, you may think that some of the outcomes that do have a positive impact are the ones that are key, most important, and therefore you might interpret the data, this evidence, differently than what has been suggested there. In addition, other implications are that various formats of aerobic exercise did not positively and significantly impact the immunologic and virologic outcomes, most cardiopulmonary outcomes, and strength measures. But given improvements on VO2 max, percent body fat, and depression in HIV patients, promotion of exercise may be supported. Again, I feel like a bit of a broken record today. I think it would be important if you did choose to support these interventions and practice that evaluation on these populations occur. So just to look at things a little bit more closely around those, particularly around the CD4 count, we did see a statistically significant impact was observed on when we compared the interval aerobic group compared to the non-exercisers, and we actually see the cell count increase to 69.58 in the confidence interval between 14 and 125, but no impact on all the other counts. So generally, the evidence does not support public health allocating resources to promote aerobic exercise among HIV populations for the purpose of improving CD4 count, CD4 percentage, or viral load. When we look at cardiopulmonary, we do see that statistically significant improvement in VO2 max. We see that improvement score of 2.63, and it ranges from 1.19 to 4.07. And that was when we just compared aerobic exercisers to non. And we also see a similar finding when we compare constant aerobic exercisers to non-exercisers. And then we see an even greater improvement when we compare heavy intensity to moderate intensity exercise, with the VO2 max being 4.30, ranging from 0.67 to 7.98. No impact on maximum heart rate or exercise time. So this evidence would suggest that if VO2 max, if that's a key outcome, then this evidence would support exercise promotion programs and aerobic exercise promotion programs for HIV populations. But if maximum heart rate or the amount of time spent was a key outcome, you may not make the same conclusion. Around strength, again, 5 of the 6 individual studies reported statistically significant improvements in strength, and therefore this evidence would support that. Around weight and body composition, we did see a statistically significant decrease in percentage body fat, and we see that that was a decrease of 1.12%, ranging from just over 2% to just over 0.01%, and also an increase in leg muscle area. However, we didn't see a change in mean body weight, waist circumference, hip circumference, waist to hip ratio, a change in body mass index, or a change in fat mass. So while the majority of outcomes related to weight and body composition were not impacted by aerobic exercise, improvement in percent body fat suggests promotion of aerobic exercise among HIV populations may be an important public health strategy. And then finally, we do see an improvement in depression dejection among exercisers versus non-exercisers, and this is likely a very important outcome here in terms of that the mental health status for these populations, and therefore the evidence at this time would suggest the promotion of aerobic exercise amongst the population. So again, overall, our findings, I think that it's hard to make a really definitive conclusion here about what to say. I think depending on how important certain outcomes are to you will significantly impact whether or not you would support using this evidence in practice or not. So I think I will leave it there at this point. So I see that we have reached the end of our webinar today, but we have one more review to go over. So if you're willing to stay on the line with us, we will go through that additional review with you. And then I can take a few questions at the end. So this final one by Farmer, published in 2008, is the effect of printed educational materials on professional practice and healthcare outcomes, evidence, and implications for public health. So our population are healthcare students and professionals. Our intervention is mass or direct mailing of printed educational materials, referred to hereafter as PEMS, and these included clinical practice guidelines. This is being compared to no intervention, and the outcome is improved process outcomes such as professional practice outcomes, for example, x-ray requests consistent with guidelines, taking adequate history, prescribing behavior, medication change, smoking cessation, and patient outcomes. So again, this was a good quality review. It received a rating of 10, 8 out of 10. And so just looking at our overall conclusions, this printed educational materials compared to no intervention led to small negative change in patient outcomes, with the effects being of limited clinical significance and no improvement in professional practice outcomes. A single intervention, so for example an educational workshop or outreach, resulted in a small change in some professional practice and patient outcomes and non-significant changes in continuous outcomes. There were no studies found comparing PEMS as part of a multifaceted intervention to other multifaceted interventions, and the reviewers were unable to determine specific circumstances and contexts in which PEMS were most effective. So overall, our implications would suggest the currently available evidence as of this review of 2008 that does not support the use of PEMS by public health as a means to improve both professional practice and patient outcomes. Decision makers may consider including PEMS as part of a multifaceted intervention, although this will require more evaluation. And although there is currently insufficient evidence related to the circumstances and contexts in which PEMS work best, future projects re-explore this literature in planning PEM campaigns. So this should be considered further. So what we actually saw when we look at patient outcomes is a small deterioration in patient outcomes across 3 studies. So in other words, patients seem to be a little bit worse off, and we're not really quite sure what resulted in that, but that's what the evidence is demonstrating. And that furthermore, there was no impact on professional practice outcomes, categorical process outcomes. For example, did they order an x-ray or not? Did they prescribe a certain drug or not? Did they engage in smoking cessation counseling with their clients or not? Nor was there an impact on the continuous process outcomes, such as changing medication. So our implications here again is that public health should not consider PEMS at this point to improve or change professional practice. And given the impact of PEMS on patient outcomes was minimal at best, PEMS may not be an optimal use of public health resources. When we look at PEMS as just one component of any intervention compared to another single intervention, one RCT showed a small positive impact on professional practice outcomes. And a single RCT showed a small positive impact on categorical patient outcomes for smoking cessation. So reduced smoking amongst some patients. However, there was no impact on continuous patient outcomes, for example, screening, turn to work, or quit smoking overall. So when using PEMS as one component of a larger intervention, public health decision makers should not invest heavily in PEMS to improve professional practice or patient outcomes. However, more evidence is needed. This is based on very limited numbers, one in this case. So again, our conclusions here are that printed educational materials compared to no intervention led to small negative change in patient outcomes and no improvement in professional practice. When a single intervention, when it was compared to a single intervention, we did see a very small change in professional practice patient outcomes on categorical variables, but not on continuous variables. No studies were found comparing PEMS as part of a multifaceted intervention to another multifaceted intervention, and the reviewers were unable to determine the specific circumstances and context in which PEMS were most effective. So as of 2008, there wasn't a lot of evidence, there really wasn't evidence to support the use of PEMS by public health to change either professional practice or patient outcomes.
So I'm just going to open it up to some questions. I realize we're over our time limit now, and thank you for staying with us. Some questions that we have, I have one here from Diane that says, interventions supported by less rigorous levels of evidence may have become mainstreamed within the health delivery system. How do we engage invested frontline practitioners in being open to better evidence? That's an excellent question, Diane, and I think that's the million-dollar question about how we do that. And so I'd be really happy to hear yours and others' thoughts on how we do that. But at Health Evidence and also at National Collaborating Center for Methods and Tools, I think this is a very complex process of engaging frontline decision makers in discussions around what is considered to be evidence, what is valued in evidence, and helping everyone to think critically about why we do what we do and how we know that what we do is actually having its intended impact. And thinking about, you know, I think of this as very small steps in terms of building on little pieces of information around why studies that haven't been done as well as they need to be done are more likely to give us answers that an intervention works. So it's slowly trying to help. I think it is. This is the way we might be able to do this, but very happy to hear your thoughts. I think we just need to be in a very sensitive way. We'll try to break research down to help everyone understand why we can trust results from some studies more than others, and to continually build critical reflection and about why we do what we do and how we know that what we do works. So that you're very right in stating there that many things get taken up into practice before we know if they work or not. And then sometimes we find out that they don't work, or even worse, that maybe they're harmful. And now we have the task of trying to stop doing those things, which is also very, very difficult. And so I think it's a long process of slowly working towards building knowledge around when we can feel really confident about results and when we need to be more critical of those results and question them. That's a very quick answer to a very complicated process, and I'd be happy to discuss that more with you or anyone else on the phone in the coming days and weeks as we, and certainly we don't have all the answers, we're still trying to answer those questions. And certainly be happy to talk about that in the discussion forum on Monday. So another comment here is, sometime take a look at the Parma campaign, Italy, that has reduced the incidence of DKA at diagnosis in children. So thank you for that, and perhaps we could be looking at posting something about that in the discussion forum. If you have any additional information that you could send us on that, that would be great. So I don't see any other questions. I really want to, okay, so I have two polling questions for you just before you leave us. And the first one is, did you find the data on these reviews helpful today? And were these findings new to you today? So if you could answer that would be great. We'll post those answers as well on Monday. I'd also be very happy to have us speak more about whether or not you think you would use the information from today during our discussion forum. So here again is just the information about the discussion forum on Monday and where you need to go. We will be there live at 1 p.m. If you have questions for us or you want to pop in and see what we have posted there and post your own comments and questions, we'd love to hear from you. And then just finally, again, you'll be receiving shortly an evaluation from Jennifer at McMaster, and just really hoping that you will spend the 5 minutes to fill that out to help us to continue to improve our services around these webinars. So I'd like to take this opportunity to thank all of you for participating with us today and for staying on the line, those of you that are still here. I know that we presented an awful lot of information today and we've gone a little bit overboard. I really appreciate your attendance, and I hope that you will be back to participate in our additional webinars that will be coming later in 2012. So thank you very much, and enjoy the rest of your day. Bye-bye.